I'll next introduce Dr. Alexandra Purdue-Smithe. Dr. Purdue-Smithe is an instructor in the Division of Women's Health at Brigham and Women's Hospital, and she'll be presenting today on pre-pregnancy migraine, or a phenotype and risk of adverse pregnancy outcomes, a prospective cohort study. And please put your questions in the chat. Dr. Purdue-Smithe.
Thanks so much for the opportunity to speak today. I'll be presenting our research on pre-pregnancy migraine and risk of adverse pregnancy outcomes. I'm going to jump right in by highlighting some of the really striking sex differences in migraine prevalence across the life course. Women are 2 to 3 times more likely to experience migraine in their lifetime than men, and women of reproductive age in particular have the highest prevalence at nearly 30%. In addition to the high prevalence of migraine among women of reproductive age, we were interested in migraine and adverse pregnancy outcomes due to their shared etiology and cardiovascular disease sequelae. So a recent meta-analysis showed that migraine, particularly with aura, is associated with 2-fold higher risk of coronary heart disease and ischemic stroke. And we also know that adverse pregnancy outcomes, including preeclampsia, gestational hypertension, and preterm delivery, are associated with 1.5 to 4-fold higher risk of CVD. Migraine and adverse pregnancy outcomes share overlapping pathophysiologic characteristics, including inflammation, endothelial dysfunction, and platelet activation, but the association between migraine history and adverse pregnancy outcomes is not well characterized. In terms of existing evidence, I'd like to highlight the recent meta-analysis from 2019, which included studies of any design that offered any adjustment for confounding. So while positive associations have been noted in prior studies, particularly for preeclampsia, prospective data is limited and included studies that were small, incompletely adjusted for confounding, and lacked information on aura, which is the migraine phenotype most strongly associated with vascular risk. So with these gaps in mind, our objectives were to estimate associations of pre-pregnancy migraine with gestational, with risks of gestational diabetes, gestational hypertension, preeclampsia, preterm delivery, and low birth weight in a large prospective study to determine whether the associations vary by aura phenotype, and to examine potential effect modification by aspirin use, given that low-dose aspirin prophylaxis is currently recommended for high-risk pregnancies by ACOG and other groups. So to accomplish these objectives, we use data from the Nurses' Health Study 2. This is a prospective cohort study established in 1989 that enrolled over 116,000 US registered nurses aged 25 to 42 years. Since cohort inception, biennial questionnaires have ascertained information on health and behavioral factors and incident disease, and cumulative follow-up has exceeded 89%. So we defined migraine as any self-reported physician diagnosis on the 89, 93, and 95 questionnaires, and any pregnancy that followed a migraine endorsement was considered to be migraine exposed. In 2007, participants were asked if they had ever experienced aura with their migraine headaches, and participants who received a migraine diagnosis prior to pregnancy and then later indicated that they experienced aura were considered to have migraine with aura. New pregnancies were reported on each questionnaire, and in 2009, participants reported details about each pregnancy in their lifetime, including adverse pregnancy outcomes. And for these analyses, we limited our sample to incident pregnancies lasting at least 20 weeks in women without a history of cardiovascular disease, type 2 diabetes, and cancer, which left us with over 30,000 pregnancies in about 20,000 women. We use log binomial and log Poisson models to estimate relative risks and confidence intervals for each adverse pregnancy outcome, and generalized estimating equations accounted for multiple pregnancies contributed to the analysis per woman. And we adjusted our models for time-fixed covariates, as well as this extensive list of updated pre-pregnancy covariates, which is a unique element of our study design. About 11% of Paris women in our sample had a history of physician-diagnosed migraine at baseline. Those with migraine were similar to those without migraine, but had a slightly higher body mass index, were slightly more likely to report a history of infertility and chronic hypertension, as well as oral contraceptive use. And migraine was also associated with a much higher prevalence of antihypertensive medications, analgesics, and aspirin in particular. Our main analysis examined overall pre-pregnancy migraine and risk of adverse pregnancy outcomes. The reference group for this analysis was no migraine, which is shown in pink, and then the comparator was physician-diagnosed migraine, which is in blue. We found that migraine was not associated with gestational diabetes or low birth weight, but was, however, associated with a 17% higher risk of preterm delivery, a 28% higher risk of gestational hypertension, and a 40% higher risk of preeclampsia in our fully adjusted models. Next, we examined associations of migraine with adverse pregnancy outcomes by aura phenotype. So just to orient you, the reference group for these analyses is no migraine, which is shown in pink. Migraine without aura is in green, and migraine with aura is in blue. And we found that the estimates comparing migraine with and without aura to no migraine were similar for GDM, low birth weight, and preterm delivery, as well as gestational hypertension. However, we did observe a qualitatively greater risk of preeclampsia for women with migraine with aura than without aura compared to no migraine. However, the confidence intervals for this analysis was overlapping, and the test for heterogeneity did not meet standard significance cut points. Given that low-dose aspirin prophylaxis is currently recommended for high-risk pregnancies to reduce risk of preeclampsia and potentially other adverse pregnancy outcomes, we stratified our analysis by aspirin use. So to orient you, in this slide, we have preterm delivery in pink, gestational hypertension in green, and preeclampsia in blue. In the left panel, we have associations of migraine and APOs among women who reported taking aspirin less than 2 times per week prior to pregnancy. And on the right, we have those associations among women who reported regular aspirin use greater than or equal to 2 times per week. We observed significant effect modification for the migraine preterm delivery association, where women with migraine who took aspirin regularly before their pregnancy nearly halved their risk of preterm delivery. We also observed a qualitatively lower risk of preeclampsia for women who reported aspirin use regularly before pregnancy, but our power for this particular analysis was limited, and P interactions exceeded standard significance cut points. There are some important limitations of our study to note. Migraine is defined according to self-reported physician diagnosis, which may underestimate the true prevalence of migraine in our study population, and accordingly the relative risks. Our assessment of aura occurred after the completion of most pregnancies in the cohort, and reverse causation may have impacted our findings if those with migraine without aura prior to their pregnancy were more likely to experience new onset aura after a preeclamptic pregnancy. While we observed a potential beneficial effect of aspirin on adverse pregnancy outcomes for women with migraine, we had fairly low power for these stratified analyses. And as in any observational study, our estimates are subject to potential residual confounding, for example, from genetic factors or migraine-specific medications. And finally, the Nurses' Health Study 2 is comprised of mostly non-Hispanic white study participants, which limits generalizability. So to conclude, our findings in this large study suggest that migraine may be an important consideration in obstetric risk assessment and management. And pregnant patients with a history of migraine may benefit from closer monitoring during pregnancy. In light of the limitations of our work, the aura phenotype preeclampsia association should be confirmed in future prospective studies, and additional research on effect modification by aspirin is needed, particularly with regard to the optimal timing of initiation and dosage. And finally, the mechanisms underlying these associations should be clarified. I'd like to acknowledge all of my co-authors as well as the funding that supports the Nurses' Health Study 2. And I look forward to your questions.
Thank you so very much, Dr. Purdue-Smithe.